For a 20-year-old, a broken bone is a painful inconvenience. For a patient in their 80s, it is an immediate threat to their life. This forest plot summarizes one-year mortality rates from dozens of clinical studies. The bottom row reveals a pooled mortality rate of 21.5%, though some cohorts see those odds climb past 34%. For those who survive, roughly half will never regain their previous level of functional independence. It's common to view the physical break in the bone as the primary cause of death. In reality, the fracture triggers a violent systemic crisis. It initiates a cascade of shock, internal bleeding, and aggressive inflammation that overloads the body's internal defenses. Stopping this collapse requires doctors to intervene across 3 distinct, time-sensitive phases of care. Phase 1 begins the second a patient reaches the emergency room. Their biological reserve, the physiological strength they had before the fall, determines whether they can survive the coming stress. Variables like advanced age, being a male patient, and pre-existing heart failure or COPD act as massive vulnerabilities. Statistically, these factors can double the likelihood of the patient dying within the year. Medical teams use routine admission blood tests to identify high-risk patients immediately. 2 specific markers act as red flags for systemic failure: elevated red cell distribution width and abnormally low albumin levels. Together, they signal the body's internal systems are already struggling to cope. Spotting these biomarkers allow doctors to move past the bone injury and begin preemptively defending the patient's most vulnerable organs. This defensive posture becomes critical during the wait for the operating room. Immobility and hospital stress frequently trigger delirium, a state of severe confusion that is closely linked to higher rates of medical complications and death. The traditional approach often involved waiting for one-by-one medical clearances from various specialists. This delay allowed the physiological cascade to gain momentum, often making the patient's condition worse before they ever reached the table. Modern protocols favor parallel stabilization. As illustrated, doctors address medical issues and prepare for surgery simultaneously, aiming for a strict 48-hour window. Success depends on opioid-sparing analgesics and targeted nerve blocks to manage pain without clouding the patient's mind. Rapid medical optimization pulls the patient out of the lethal cascade far more effectively than the mechanical act of surgery alone. Patients surviving the hospital stay still face a difficult recovery trajectory at home or in rehab. Post-discharge mortality is predicted by readmissions, the onset of postoperative atrial fibrillation, or even missed follow-up visits. This recovery period requires constant surveillance for secondary complications like pneumonia, new infections, or recurrent falls. Surviving the first year depends on maintaining unbroken transitional care well after the patient leaves the surgical ward. Addressing such a systemic injury requires an orthogeriatric model, where surgeons, geriatricians, and therapists work in lockstep as a single unit. As global populations age, the total number of hip fractures and their associated healthcare costs will climb exponentially. Recent research confirms that treating a broken bone in isolation without managing the systemic fallout is an obsolete strategy. Ultimately, a meticulously connected preventative healthcare system provides the single most effective long-term cure